You know, when it comes to new medicines, we all want one thing: proof. Proof that it's safe, proof that it actually works. Simple, right? But what if the very system we built to get that proof is the biggest roadblock for people with the rarest diseases? That's what we're digging into today, this huge, critical evidence gap.
And this is so important to remember. This isn't just some dry academic debate about statistics. This quote really hits home that behind every single one of these decisions, there's a person, a mom, a kid, an entire community just waiting. Decisions about data have real, life-altering consequences.
So, here's how we're going to break it all down. First, we'll tackle what's called the gold standard paradox. Then, we'll get into the patient's point of view and the growing call for new kinds of evidence. From there, we'll get practical. How do you find these gaps? How do you build a better study? And finally, what's the new path forward? Let's get into it.
All right, Section 1. Let's start with the big paradox here. Imagine you have the best, most precise tool in the world, but you're trying to use it on a job it just wasn't built for. That's kind of what's happening here. We've got the pinnacle of medical evidence, but for some of the rarest diseases, it can actually backfire.
And that tool is the randomized controlled trial, the RCT. You've probably heard of it. It's been the gold standard forever, like since the 60s. The idea is brilliant, really. You get a big group of patients, randomly give half of them the real drug and the other half a placebo, and just see what happens. It's how we know for sure that drugs for things like high blood pressure or diabetes really work.
But here's where it all falls apart for rare diseases. For a common illness, you can get thousands of people for a trial. Any weird individual differences just get smoothed out in the average. But for a super rare disease, you might only find, say, 30 people in the entire world for your study. In a group that tiny, just one person who responds differently can throw off the entire result. The math just doesn't work, even if the drug is a miracle for almost everyone else.
And listen, this isn't just some fringe idea. This is a quote from Dr. Janet Woodcock, a major figure from the FDA, and she puts it so perfectly. If you know a trial is basically set up to fail mathematically, why would you do it? It's not just a waste of resources. She says it crushes the hope of people who are already in a desperate situation.
Okay, so we've talked about the science and the math, but let's shift gears now to the human side of this. What does all this actually feel like for a patient, for a family caught in this evidence gap?
This slide really nails the communication breakdown. You've got the official bodies, the HTAs, looking at the numbers and saying something very clinical. There isn't enough evidence. It's objective. But what does the patient hear? What is the family that's been fighting tooth and nail for years hear? They hear, "You're not a priority." It's just devastating. And the result of this disconnect is just maddening. You can have a new therapy that gets the green light from the biggest regulators in the world, like the FDA or the EMA, but then it gets shot down at the local level. It creates this cruel lottery system, where whether you get a life-saving drug depends on where you live, not on how sick you are.
So, you can see why there's this huge push for change from patients and researchers. They're calling for a fundamental shift in how we think. It's about letting go of the hunt for perfect evidence, which, let's be honest, might not even exist, and instead learning to work with the best possible evidence we can get.
So what does this new way of thinking look like? Well, a few big things. First, you have to just accept that there's going to be some uncertainty. You can't escape it. Second, you look at all the evidence, not just the gold standard stuff. That means listening to patients, valuing data from their real lives. You also have to look at data from registries and doctors' offices. And maybe most importantly, you have to consider how hard it was to even get the data you have.
Okay, that all sounds great in theory, right? But what does it actually mean? How do we go out and find this best possible evidence?
Well, this is where it gets really interesting. It doesn't start with jumping into a new study. Nope. It starts with a search. Think of it like being a detective or a map maker. You have to systematically figure out what's already known so you can pinpoint the exact gaps in our knowledge. And it's a very organized process. You don't just start Googling randomly. You sort your questions into clear categories. Things like, how many people have this disease? That's epidemiology. Does the treatment actually help? Clinical outcomes. Is it safe long-term? That's safety. It keeps the whole process focused. And the search happens in layers, kind of like a funnel. You start really broad with the big databases everyone knows, like PubMed. Then you get more specific, diving into places like Embase or Cochrane. And then you go even deeper into what's called gray literature, stuff that's not in the big, fancy journals but is still super valuable, like reports you'd find on Google Scholar.
Okay, so you've done your homework. You've found a gap. Now what? Now you have to build a smart study to fill it. Because, a perfect answer to the wrong question is completely useless.
The starting point for this is a great little tool called the PICO framework, PICO. It forces you to be super specific. Who are the patients? What's the intervention? Who's the comparison group? And what's the specific outcome you're measuring? It's all about making your question crystal clear right from the get-go.
But just being clear isn't enough. Your question also has to be good. And that's where you pressure test it with something called the finer criteria. You ask yourself, is this actually feasible? Is it interesting? Is it novel? Is it ethical? And the big one, is it relevant? Like, will the answer to this question actually make a difference for a patient? If not, why are we doing it?
And this is a great little chart because it shows there's no one-size-fits-all study. The question you're asking determines the tool you use. If you just want to understand the basics of a disease, a simple study will do. But if you want to compare two different treatments, well, you're going to need something much more robust. It's always about picking the right tool for the job.
All right, let's pull all this together. What does this new path forward actually look like? At its core, it's pretty simple. Stop trying to jam a square peg into a round hole. It's about building a system that's actually designed for the realities of rare disease.
And this new approach really boils down to 5 big ideas. 1. Be okay with a little uncertainty. 2. Think about what's actually possible to prove. 3. Open the door to all kinds of evidence, especially from patients themselves. 4. Get smarter about judging the quality of that different evidence. And 5. Look at the whole picture, the totality of evidence. Don't just wait for that one perfect study that may never come. I love this quote because it just sums everything up. Nobody is saying let's lower our standards. Not at all. The ask is to be smarter. It's about rethinking where we place the bar to make sure it's in the right place for the challenge at hand.
And really, that brings us to the final question we have to ask ourselves. We've seen the human cost, the delays, the unfairness, the lost hope. So it's not really a question of can we adapt anymore. The real question is, how can we possibly afford not to?